Okay, well, welcome everyone to the Rehabilitation Modelling Resource. I've already got an echo, so I'm wondering if everyone's got their microphones switched off. So if you could, I can start by asking you to switch the microphones off, that would be great. Thank you. Great. So my job is to introduce everyone to today and take you through the event. So welcome to this warm and sunny afternoon, and I hope nobody melts during the event because it's quite warm. So my name is Claire Madsen, and I've been the co-chair with Ruth Crowder, Chief Allied Health Professions Advisor of the Welsh Government Task and Finish Group looking at rehab during this project. As a consultant physiotherapist who has specialised in neuro and rehab, I feel as though I've been flying the flag for rehab for more than 30 years, so I've been thrilled to be part of this. As some of you may know, I'm both new to the role and new to Wales, only having been in power since January this year, and I felt really privileged to be working in Wales with an all-Wales team of people who are so creative and driven and who are really able to make a difference. This group was tasked to look at rehab post-COVID, but also to consider what rehab should look like going forwards. Rehab has often been an overlooked area, rarely commissioned specifically, and often seen as a nice-to-have service rather than an essential service. COVID has given us the opportunity to demonstrate how essential and life-changing rehab is, and how it's everybody's business and not just the work of a few rehab specialists. This has been a very exciting piece of work, bringing together practitioners from a wide range of backgrounds and organisations, looking at how we can all work together to deliver the best offer to the person requiring the rehab. It's been incredible to see what can be achieved at pace, and we're very proud of the deliverables that have been published in the Welsh Government website under Rehabilitation Coronavirus. And I can see that Ruth's already made the link available in the chat on the side, and it's probably been sent to everybody as well. So today's event is to demonstrate the model that's been designed by this group and to look at opportunities for you to become involved, to trial the model and input into a new final version of the model. We're really delighted to welcome you all today and see so many of you, and we really encourage you to participate by asking questions in the sidebar, which the panel will endeavour to answer both as we go along and also during the panel session. We'll put together a set of answers for things that we're unable to answer today. We also want you to participate by signing up to be a test site. We can see that a high proportion of you have already expressed an interest in this when signing up, and there will be more information about next steps at the end of the presentation. I would like you to note that by expressing this interest, you are agreeing to your name being held on a list for us to be able to contact you in the future. So if you're not happy with this, please let us know. We want you to give us feedback both during and after the event, and we will make the slides available to those who've signed up and attended. We've also been recording the event, and the recording will be made available to watch alongside the FAQs at the end. As this is a virtual meeting, we ask you to kindly follow the virtual etiquette. So just reiterate, please turn your cameras and microphones off if you're not speaking, and please bear with us if we have the odd technical hitch. Also remember to put any questions that you've got into the chat on the side, because we won't be using the hand up facility today. So it just leaves me to introduce our first speaker, Jackie Thornton, who has led this fantastic piece of work around rehabilitation modelling, and say that I hope you all enjoy this session today. So thank you very much.
Thank you, Claire. For those of you who know me, you'll be aware that, like Claire, I'm incredibly passionate about the difference that rehab makes, both from an individual perspective, a community perspective, but also in relation to the wider economy. The development of this modelling resource for rehabilitation, I think, is an exciting and much needed tool. And what we've done is complete it in partnership between practitioners, service leaders and modelling staff, so that we can use a combination of the skills and expertise in order to develop it. It'll be evident from the presentations that will follow that I'm enormously grateful for the commitment, time, support and talent demonstrated by all those who have contributed to get the modelling resource to this point. It's been an exciting and novel journey. I'm not a modeller. I'd had very little to do with modelling before I started working with this group, and leading it was a challenge by any means. Almost all of us had no prior experience of developing a mathematical model within healthcare. But since the start of this group, we've become more and more convinced of the value that modelling can add to the way that we deliver care and support services. Many of you will have no previous experience of using models to influence service delivery, but I hope that we can provide a sufficiently simple overview that will enthuse and motivate you to understand more. This will not be your only opportunity to be part of the modelling network and to move things forward. Just thinking about rehabilitation, what I see is that it can be difficult to understand and coordinate services. Teams and agencies often offer different elements of provision. There's a variety of approaches, either for specific conditions or in different geographic areas. And it's often difficult to predict the type or level of rehabilitation that's required, making it challenging to agree what the demand is, what the capacity to meet that need is, the costs, and how we might deliver it most effectively. Increasingly, care services are using modelling to help service leaders and decision makers understand and predict the demand on the service so that they can adapt and flex their response to ensure that care needs are met. COVID has provided us with a clear example of where modelling was used to predict the potential impact of the virus and enable services to plan and respond to the change in demand. By using the evidence available, practitioner knowledge and experience that emerges from COVID, the rehabilitation model has been developed as a representation of the system that's required to meet rehabilitation needs, both during and following the pandemic. It can be used to enhance understanding, help us to highlight areas of strength or gaps in relation to rehabilitation, and unpick local and national demand that allow us to optimise the use of our resources. Ultimately, the model will help rehabilitation services to respond to the needs of the community, and that will serve as a systematic and coordinated way in supporting the delivery of real person-centred care. Can we go to the next slide, please, Colin? It's important that all participants today understand that we're at the start of developing this modelling resource. This is our first model, and while it's been designed in response to the COVID pandemic, it actually is suitable for use at usual times in all areas of practice and across all organisations. It will need to be tested across the age spectrum with those who have acute, longer term rehabilitation needs, by teams in Wales who work with people including children, older people, those with mental health concerns, to name a few. And we need to work alongside you to further develop the model, which in turn will enable organisations and teams to improve the configuration of their rehab services for all people in Wales. The term rehabilitation is used to describe those interventions that enable a person to make the journey towards regaining or improving their ability to live the life that they choose. This view of rehabilitation is inclusive of interventions, whether we call them specialist interventions, generalist interventions, reablement, recovery, or any other term that might be used to describe the constructive journey that we support someone with. This is not just focused on NHS or acute care. I think that's been one of the concerns in relation to it being wrapped around COVID, but is designed to work across the continuum of rehabilitation and reflect the ways that rehabilitation is delivered by multiple agencies in different settings, in different ways, and to reflect geographic and demographic distinctions. I hope that the enthusiasm of this group that you will see today will encourage you to take the journey into modelling and consider how you can use these tools to help you understand the demand for and provision of rehabilitation services at a local and national level. The group has made an exciting start to developing the modelling tool, and we are in a unique position in Wales to develop this work to improve, evaluate and design the way we deliver our rehabilitation services. Ruth has mentioned at the side, and Claire also mentioned, the work that's been done across Wales by Welsh Government in pulling rehab guidance and the framework together. And this work has linked up very strongly with that. So on the slide in front of you, you will see the population cohorts that were identified as part of the framework. You will hear more about these as we move along, because these have been very integral to the way that we've developed the model at this stage. And I will pass then over to the others who will describe in more detail around how we do that. Initially, we will only be focusing today on population 1, but the model has been developed and is suitable for all the other populations and will require testing. Thank you for attending. We're absolutely delighted to have such an amazing response to this event. And hopefully I look forward to seeing you all at future events when we're taking this further forward and you are really engaged in that modelling process. Thanks very much.
Thank you very much, Jackie. So I'd now like to invite Michelle, Jenny and Susan to join us, and they're going to explain how they actually came up with the model.
Thanks, Claire. So in this section, we're going to explain the clinical principles we use to develop the modelling tool. We're going to give you an overview of the tool, describing it and again how it was developed. The detail on how to use it will be provided later on. We're also going to introduce you to the evidence used to inform the modelling tool. Next slide, please, Colin. So as we all know, rehabilitation is a complex intervention and it crosses many specialities and geographical locations. Many current rehabilitation models and pathways are designed around specific diagnosis or age-based criteria, and this is resulting in some gaps or inequities. These gaps and inequities were highlighted during the COVID-19 pandemic, with some individuals struggling to access services due to the diagnostic or age-based restrictions. So in developing this tool, we used a number of principles. As Jackie said, we started looking at pathway for population 1, so those individuals who had COVID-19. We used information that was emerging from intensive care units in London and across Wales. This information was based on the UK Rehabilitation Outcome Collaborative definitions for levels of speciality rehabilitation. We coupled this information with the patient categorisation tool to develop a pathway of care for people who had had COVID-19. However, this only focused on the inpatient aspects of rehabilitation. Linda Chandler and Kerry Phipps were instrumental in adapting the right sizing model alongside the decision support tool for continuing healthcare to develop the pathways across both the inpatient and community-based settings. All the way through this process, we tried to approach it from a prudent and value-based healthcare perspective, so ensuring we were patient and outcome focused rather than service or place focused, and trying to work right across that continuum of care. We were also keen that it fitted with the 6 components of care that have been identified and discussed in the rehabilitation guidance paper. Once we'd devised the pathway for population 1, we then applied it to the other 3 populations that Jackie's highlighted. We felt the pathway did fit with all 4 populations and that it could also be provided to prehabilitation. Next slide, please, Colin. So in this slide, this shows the model principles. The model, as you can see, is not focused on a geographical location of the services, and it's based on the needs of the individuals, not their diagnosis or their age. You can see the 4 main boxes there that illustrate the range of intensity of rehabilitation need. The red box being your most intensive, through to the green box, which is emphasising the importance of rehabilitation outside of the health and social care setting, so involving our third sector and leisure industry colleagues. In each box, you can see an average time spent at stage. This shows the time that the individual tends to spend in each of those intensity settings. Alongside this, you will see the number of hours per day. This is not the hours per day of direct therapeutic intervention, but the hours that the individual will be engaged in the rehabilitation approach. Under each of those boxes, you can see the heading psychological, cognitive and physical with a percentage attached. This is to illustrate the differences between the intensities within each of the sections. I must stress at this point that the physical box includes everything that is not psychological or cognitive. And it's been done purely for illustration simplicity.
Oh, hi.
The red circles on the diagram there are to highlight that rehabilitation in its entirety can't be delivered by one element of care, and a collaborative.
Sorry, Susan, we've got a small issue. You've been muted.
Oh, from when, Jenny?
So just the start of that sentence. So you're fine. I just caught you.
Oh, thank you. So if we could go back to the slide, Colin, with the model on it, please. That's lovely, thank you. So the red circles on the diagram are to highlight that the rehabilitation can't be delivered by one element of care. So it's a collaborative partnership approach that's required to ensure that rehabilitation is the most effective and produces the highest quality outcomes for the individual. So I'm now going to hand you over to Jenny, who's going to explain in more detail how the model was developed.
Thank you very much, Susan, and sorry to interrupt you there, but you were in the flow, so I thought I'd just jump in. So thank you very much. So for those of you who don't know me, my name's Jennifer Morgan. I work for the NHS Wales Delivery Unit. I am not clinical. I'm not a rehab expert, although I'm nursing a sling at the moment. And I had the privilege of being part of this project in order to work with everybody in order to actually build this model. So what we've got on screen at the moment is a high-level summary of that model. But if, Colin, we can move to the next slide, or if you don't mind me taking control of your screen, I can take us to the next slide. So what I just wanted to revisit was, how did we actually develop this model? Because I wanted to offer reassurance to the group about this robust process that we've gone through. And what Susan's alluded to is all of that clinical engagement, but I want to assure about that approach and methodology in terms of how systematically we then pulled this information together. So any model, what we want to do is have a very clear aim. So in this particular programme of work, we were talking about what demands will service face and when. So I'll then also pick up on what the approach is. So I'm conscious that when everybody was feeding back on the Eventbrite form, we had a large number of people saying that actually they're not familiar with modelling. So I just wanted to touch upon what is modelling. But rather than try and introduce you to that whole field, I'm just going to be a bit more specific and talk about what is operational research modelling in the context of this work. So all we're talking about with a model is a representation of a situation in order to aid understanding and to support decision making. So the first versions of the models that we're talking through at the start of today's session are very much a pictorial representation. It's more of a qualitative model, but that can still have value and a really robust support tool. What we're talking about, though, is trying to go through a systematic process that those of you from improvement land will obviously recognise how this has a similar approach to a PDSA cycle, where we're understanding the problem, devising a conceptual model, so that picture, and then formalizing it into some sort of formal model, which may or may not be mathematical. And the reason that we're doing this, you've heard reference earlier in this discussion to the right sizing community services work. So the right sizing work, we had the privilege of being able to actually tap into an existing model and just put some maths behind it, okay, in order to actually generate that estimation of what demand will be facing our services and when. However, for this rehab work, we didn't have that base model to pick up from, and so we've had to go to the we had to put the effort in order to actually develop the model. So we're going through this iterative process in order to do that. So what might a model actually look like? I've just got a bit of a graphic here to illustrate how a model, as I've said, could be a picture, and I've got an illustration of the London Tube map here. So we know that this is not a good geographical representation of London, but it's to aid in a passenger or the planner's understanding of how trains will be moving around the capital. So if we were to start to overlay actually what London physically looks like, it's a little different. And that's what we're doing with our modelling here. So the approach that we actually used in order to develop this model, again, it's grounded in research. So we were using an operational research problem structuring approach, hugely collaborative, as mentioned by Susan. And what we're trying to do is create some conceptual models. So we're laddering through in order to create initially a cognitive map, or some sort of map in terms of what each individual who was contributing to this project, what their view of a rehab model might look like, and then we were collating all of that together. So what I'm just going to have sort of spinning through next is this is all the different iterations of the model that we went through. So we were keeping a log of this, and you'll notice how we started out with a really simple model, and then it started to get a bit big and messy, and then we had to make it a bit simpler again, and then we got our red pen out and we started rejigging it, and then this is our final output in terms of that cohort 1. So on the slide that Susan was sharing, she was focusing in on those coloured boxes, talking about that red box versus the green box. So exactly the same, but now what we've got is a clear delineation in terms of that flow in. But again, we were making reference to the question, our aim of our bits of work, in that it wasn't just about creating a picture. What we wanted to get to was a view as to what the numbers of patients, the amount of demand would look like over time. And therefore, we had to start taking into account things such as the proportion that are flowing, but also the time that we would expect patients to be spending at any particular stage. As mentioned by Susan, my colleague Richard will be talking everyone through how to actually get the model working for them. So now I can hand over to Michelle, who'll be picking up on the evidence that informed that and helped build some of those earlier pictures.
Thanks, Jenny. In May, we didn't know how many people might be affected by COVID. Sorry, next slide, please. How many people might be affected and what their rehab need might be. And we didn't know what the impact of stopping normal services would be on rehabilitation either. So the first point of call was to look at the research evidence. So Julie Highfield and I looked at the emerging evidence around COVID from China, Italy, and London. And early reports from China were 81% of people with COVID presented with mild symptoms, with 14% with severe respiratory dysfunction and another 5% with a critical illness. So we kind of used this to say that we thought only 20% of people with COVID would likely require a hospital admission. To understand the real demand for patients admitted with COVID, we looked at the COVID-19 hospital discharge service requirements. They were published by NHS England, and they outlined 4 parts based on audit of people discharged from the London hospitals in the early days, and they put estimates around the proportion of patients likely to be on each pathway. The evidence base has continued to develop, and we use in this model likely to change as we understand more about COVID. For the populations 2, 3, and 4, again, I went back to see if there was anything in the literature. Anne Price and Colin Gibson looked at some of the literature from natural disasters, such as the earthquake in New Zealand or the tsunami in Japan, as well as pre-disease. So with man-made or natural disasters, such as bombings, hurricanes, earthquakes, they tend to increase trauma-related hospital visits. And this is usually acute, and it doesn't last for weeks and months. And it's also associated with physical damage to the hospital sites, homes, and the infrastructure. But there was some literature around the effect of MERS and SARS for causing longer-term reduced exercise tolerance and fatigue. SARS in Toronto resulted in restriction of hospital services, and they took months to years to recover. Also, we knew that the quarantine during SARS outbreak caused anxiety, depression, and even PTSD. So it's difficult to extrapolate that from that literature to use in this model to determine needs. Sam Pereira from DU used information to compare the levels of healthcare activity for planned and unscheduled care from previous years with the periods of March to May this year for things like cold orthopedic surgery. But there was a real lag in the reporting and the data, and it made it difficult to use this. There were some local audits undertaken, so simple snapshots of who were in hospital beds at the time and what sort of rehab they might need. Some of you may have been involved in those. And we also used the information that was fed back at the last engagement event. So particularly the stories from practitioners in the community were really helpful. So we know this, the data used in this is not right, and we've made large assumptions. And as we said before, this is the first iteration. But as we understand the impact of COVID on a wider health and social care system, we will be able to refine the tool and make it more accurate. We have to look at the data we capture in order to do this. So at the last point on the slide, there is some guidance on identifying the demand for and evaluating the impact of rehabilitation. That was developed as a part of the overarching rehab project, and that should support better data capture. Next slide, please. So for this event, as we've said, we're going to be looking at cohort 1. So Jenny and Richard will be taking us through the model in more detail, but for the practitioners amongst us, it might be useful to keep these patient scenarios in mind. So they're taken from the rehab guidance, which has also been published on the Welsh Government web pages. So somebody like Michael, he's likely to enter rehab at that high intensity complexity stage, and he may well move through every stage before he exits. Next slide, please. Whereas for Mabel, so she would enter the model from the community, and she might enter in the low complexity box. If you add together her engagement time and her actual direct rehab time, she might get up to 3 hours of rehab a day. And again, she may then step down to the monitoring box, or she may then finish and actually and to talk about how we into a predictive model. The practitioner point of view involved in this don't quite understand what rehabilitation is, and how the complexity and lament and say how difficult this was going to be, and somehow the model has managed to actually simplify everything we said was difficult into some really simple diagrams. Back to you, Jenny.
Thanks very much, Michelle. I'm conscious that sound was a wee bit difficult for a few people there, so apologies about that. Just as a wee reminder, could we ask everyone to mute their microphones, just because the microphones pick up sound even if you're not talking. But thank you very much, Michelle. That's really, really helpful. Colin, I'm going to take control back off you again a second. Some might say it's the control freak in me. But as Michelle was saying, what we wanted to do is, yes, we can create that picture. And, yes, it was a huge amount of evidence for all of the team to go through, and we worked hard in order to collate that together into a useful picture. What we've then devised is an Excel-based model, but those of you who have information teams or analytical colleagues who want it in a different platform, we're working on that as well. But what we've got is some simple parameters in there so that you can actually change the flow within that model. So some of the uncertainty that Michelle has alluded to, actually, it was more just about the parameter values rather than the overall model structure. And that's what we'd be interested in everyone's views from. So a lot of you will be familiar with these sort of flow models. So this idea that we've almost got these bathtubs going on, where we have patients coming in at the top, a rate at which they're moving, filling up a tank, spending a period of time there and moving through. So this is quite an old diagram, but the idea is to illustrate that for this model, what we're doing is, yes, we're trying to capture the flow that a patient will be going through, but it is not an individual pathway based model. What we're trying to do is represent that overall flow and how it all accumulates in terms of patients and the demands that they have at different points. So if I just scooch forward again. Sorry. So on that mathematical model, those of you familiar with it, what we'd expect is we'd refer to these purple boxes as our levels or stocks, or in our case, we're going to refer to them as our stages. Oh. Sorry, I'm having trouble at the moment with the slide deck. Okay, so we've got that mathematical model that we can push it into, and the idea being that once we can actually have this illustration. Oh, I'm sorry, I'm not quite sure what's happening with the slide deck. Colin, are you in control of the slide deck at this point in time?
I'm not. I think there are a few glitches on the system. It's jumping around a bit.
No problem, thank you. Apologies, everyone. So the aim is that we can get outputs that are in the form of graphs over time. So what is our demand on the service for these different cohorts, and how do they accumulate and spread out over time, and where are we seeing them in the system? So at this point, I'm going to hand over to my colleague, Richard Sullivan, who's going to walk you through how to actually use this model in a more practical sense. So taking this exact model and actually plugging it into the simulation or in the tool. Richard, can I hand over to you?
DJ, I'm just going to present my screen. Hold on. Teams has decided to be quite slow on this hot day. Can everyone see my screen?
Yeah.
Yes, we can, Richard.
Excellent. So yes, I'm Richard Sullivan. I'm a senior information analyst for the delivery unit. And just like Jenny, I am not clinical. I am just one person who sits behind a computer. So I'm going to be spending the next 20 minutes also explaining and demonstrating an understanding of the rehabilitation model. And what I'd like to cover in the time is scenario 1, where we'll be looking at simple percentages for the model, average time spent at stages, then moving on to scenario 2, looking at the laddering aspect, also known the transition between the stages. Then we're going to be showing a demonstration of 3 different scenarios in actual data going in the model. So the rehabilitation model is a tool used to demonstrate the likely impact of different admission rates and the potential changes to these intervals and change over time to show the demand for each of the stages and the service as a whole. Firstly, I think it's important I mention that this is not how I expect users to run the model. I'm just building through and giving examples, walking and talking how it works. In very simplistic terms. So this slide shows cohort 1, focusing on cohort 1A and 1B, looking at 1,000 admitted patients coming in at one of the stages. Following the rehabilitation documentation, I'm going to be keeping and following the same percentage principles for each of the stages that our initial 1,000 admitted patients will enter. So if we can see, 5%, a total of 50 patients, enter high intensity rehab. 25%, that's 250 patients, enter moderate intensity. 20%, 200 patients, enter low intensity. And 50% of 500 patients enter the no further rehab needs or short-term monitoring. We then bring in cohort 1C, looking at the non-admitted patients. The number we have in this example is 4,000, as the calculation is 4 times that the admitted number. So we have 90% of these 4,000 patients entering no further rehab needs. That's an additional 3,600 patients, bringing our total for this stage to 4,100. That's because we also have 500 patients that entered from cohort 1A and 1B. We then have 10%, that's 400 patients entering lower intensity rehab. That's bringing that stage to a total of 600 patients. And again, that's because we had 200 patients coming in at cohort 1A and 1B. Now, currently, there's a 0% chance of these patients moving to another stage. However, 100% chance of them being discharged or exiting the system after their duration. Now, I know that this isn't a true how a service operates. However, this just demonstrates what one box or stage would look like if all patients left our intensity at once, which again, I know isn't realistic to a service. However, in scenario 2, we're going to be discussing and demonstrating the moving of patients from one intensity to a lower level of intensity. For the purpose of illustration, anybody entering the service will stay in the initial stage of cohort 1A, 1B, and 1C for an average time of 2 weeks before they access another intensity. The reason behind this is for the ease of explaining and demonstrating within the presentation, and for the ease of displaying within our model. So as I mentioned, all patients coming in cohort 1A, 1B, and 1C will stay in the stage for 2 weeks. The patients who enter high intensity will stay for 4 weeks, 8 weeks for those patients in moderate intensity, and for the patients in low intensity and no further rehab needs, will stay in for a duration of 6 weeks. The entire duration, a time a patient can stay in the system, is 1 year, 52 weeks. After that, they exit the system and no longer counted. So we now are going to move on and discuss the laddering aspect of the model, knowing the percentage of patients who transition or move from one stage to the following stage. And in this example, we have 100% of the patients moving into the next stage once the duration from their initial stage comes to an end. So we start off at the high intensity stage. After the 4-week duration, 50 patients leave high intensity and will enter the moderate intensity. This then brings moderate intensity to a total of 300 patients. After 6 weeks, the 600 patients in low intensity will then enter no further rehab needs. At the exact same time, the 4,100 patients in no further rehab needs will exit the system. So we now have 0 patients in low intensity as they have moved to the no further rehab needs, and we have 4,100 patients that have exited the system. We now go back to moderate intensity. After 8 weeks, the first 250 patients leave moderate intensity and will enter lower intensity. The 600 patients in no further rehab needs will then exit the system as their 6-week duration has come to an end. So we can see we have 50 patients in moderate intensity, we have 250 patients in low intensity, and we have 0 patients in no further rehab needs, because 600 patients exit the system, bringing our total to 4,700. The remaining 50 patients in moderate intensity then enter low intensity, bringing our total to 300 patients in low intensity. But you can actually see for the first time we do have capacity in other stages. 2 weeks later, the 50 patients leave low intensity, then enter no further rehab needs, leaving the remaining 50 patients at this stage. The remaining 50 patients leave low intensity and enter no further rehab needs after their 6-week duration. Again, bringing the total number of patients at the stage of 300. "250 patients leave no further rehab needs and exit the system after a further 2 weeks, leaving only 50 patients in no further rehab needs." So we now have 4,950 patients that exit the system. After a total of 26 weeks from when they entered the system at cohort 1A and 1B, the final 50 patients leave no further rehab needs and exit the system, bringing our total patients discharged to 5,000. And that is how laddering in the system works in our model. We're now going to look at scenario 1 at the plan and demonstration. But before I go into the detail with the data, I'm going to show you the front end of the model. So just like the previous slides, it's exactly the same in how it works and how it looks. All the percentages are the same as we're working on the documentation. And the only difference between this model and what I presented in my laddering example was this expands the transition laddering between the stages. So the example I gave was patients who are in high intensity, they move into moderate intensity into low intensity, and low intensity into no further rehab needs. However, if your service required, patients in high intensity can move into lower intensity, or they can move into no further rehab needs. Or if it requires, they can exit the system. Because it's a surge and we're starting off at an empty system, we will focus on the additions page. And this additions page is where you input your data, which then allows an output within the model to see how it's all represented. But working through the first part, as discussed, we're going to be looking at 1,000 patients at cohort 1A and 1B, and 4,000 at cohort 1C. So let's see how this looks in our output. So this is the output of the model. As we can see, we have our total patients, 1,000 at cohort 1A and 1B, and 4,000, because it's 4 times that, the number of admitted, in cohort 1C. We also know that their total duration at these stages is 2 weeks. 2 weeks before they then move into the next stage. And we can see at period 16, the patients leave cohort 1A, 1B, and 1C and move into the required stages. So we have 50 patients in high intensity, 250 in moderate intensity, 600 in lower intensity, and 4,100 in no further rehab needs. We then know that after their duration within these stages, they then move into the next stage. So at period 44, patients then move from high intensity into moderate intensity. And both the patients waiting at lower intensity and no further rehab needs, they move into the next stage at period 58, or exit the system. So this is exactly the same example I showed earlier in the slides. However, we can see at first hand how it works in the model. Not only on the output page do we have the data aspect, next to this we have charts. And this just represents the data collected from the table. So we can see from this chart that we had 0 patients at cohort 1A, 1B, 1C. This then shoots straight up to 1,000 for cohort 1A and 1B, and 4,000 to cohort 1C. They then stay in these stages for the 2-week period, before they move or transition to the stage required. And this is what it looks like with all stages. There's a lot to take in, but we can just see that we have the patients 50 at high intensity before they move into moderate intensity. And there's the 250 patients with the 50 patients coming in to bring it to 300. So in scenario 2, we're going to take an intermediate step and look at the duration over time. And this is looking at 100 new patients coming in per day for 10 days. So from my previous example, we had that static 1,000 patients for the duration. However, if we put in 100 patients and then drag this down for 10 days, let's see the impact it has on our model. So we have the 100 patients at cohort 1A and 1B, and then the 4 times number in cohort 1C. So let's have a look at the output. So we can see that at period 1, it started as empty because we had no patients. At period 2, we have the 100 patients, but then it's changed at period 3 to 200. Now, why is this? It's because we have the 100 patients from period 2 and the 100 new patients at period 3. So it's 100 plus the 100. At period 4, we have 300 patients. Again, same principle. It's the 100 patients at period 2, the 100 patients in at period 3, and the brand new 100 patients coming in at period 4. And this so on continues until we get to period 11, which is our 10th day. Just like before, they stay in this stage for 2 weeks before we see at period 16 the transition or the move to the next stage takes place. And just like previous examples, the patients stay in the required stage for the duration of their period. So at period 44, we then see patients then from high intensity move into moderate intensity. And the patients who are in low intensity and have no further rehab needs, we then see the move to the next stage at period 58, where the low intensity patients move into no further rehab needs, and the initial patients in no further rehab needs exit in the system. Again, this is displayed in the chart. So even though we have from 0 to 1,000, it's not such a dramatic or shoot up like the last chart. We have that gradual increase over the 10-day period. We then see them stay before they start to move within the required stages. And this is just a chart of all the stages showing exactly the same data that we had in this output data chart. So we now move on to my final example, where we take a look at actual SITREP COVID admissions data. The data period I've picked out is from the 23rd of March up to the 3rd of August 2020. So that's a 20-week period. This is actual health board data that we've got permission to use. And this just shows, so everything I copied in cohort 1A and 1B, it's then an automatic calculation of 4 times that for cohort 1C. Let's look into the output side. So we see at period 2 and 3, there's 0 patients. Now I know actual real data, you probably have stroke rehabilitation patients or those patients who just had accident. So there would always be some sort of numbers in here. But because I'm using COVID admission patients, no admitted patients were at these 2 periods. We had some patients then come in at period 4 of 126 patients. So it matches. At period 5, this increases then to 172. And just like the example and my explanation, scenario, the last example, scenario 2, that's because we have the 126 patients at scenario 4, as well as the brand new 46 patients that have come in at period 5, bringing our total to 172. Again, same principle for period 6, 216. And that's because we have the 126 patients at period 4, the 46 patients at period 5, as well as the new 44 patients coming in at period 6. And this builds where they stay in for this stage for up to 2 weeks. But there is a difference in this example. So in my previous examples, come period 16, that's when the first move into the next stage takes place. But we can see that there is no move in this example. And that's because at both period 2 and 3, there were no patients to move across. So the move takes place at period 18, where they then start to move into their required stages: high intensity, moderate intensity, low intensity, and no further rehab needs. And just like my previous examples, the patients stay at their initial stage before they start to move into the next stage across. And this can be, and I'm now going to show you how it looks in the chart. So for the first time, we actually see what realistic health board data looks like. So looking at and concentrate on cohort 1A and 1B, we can see that we had 0 patients for the first 2 periods. We then had 126 patients, and this keeps on continuing up to, and I'll show you, I'll go back one, whoops, up to period 17, where we had a grand total of 162 patients, 172, sorry, my apologies. Before we then see the move, the transition, where patients then move into their required stages, where they keep going into those stages up until there's no more patients in either cohort 1A, 1B, 1C. And this is what it looks like. The chart results, the table of looking at all stages. I have included some caveats for using the SITREP data, just for precaution. And unfortunately, sorry for everyone, I've gone slightly over. Thank you for listening. That's me. Thank you.
Thank you very much, Richard, and I think everyone's been really happy that there's some clarification and some clear explanation of how this works. So thank you. And I can see it generated lots of questions in the question bar. And somebody said to you, Richard, that they wish you'd been their maths teacher. So that's got to be the ultimate compliment, hasn't it?
Thank you very much.
So what we're doing now is we're going to move on to a question panel. So firstly, I'd like to invite Michelle, Jenny and Susan and Jackie to join us again, because they'll be answering some of the questions. And I'd like to start with Jenny, because there was a question that came up about just clarifying how the lag works and how the movement goes from one level to another. So since we're at that, we've just finished covering that point. Do you want to elaborate on that one now, Jenny?
No, absolutely. Thank you very much, Claire. No, so I think it's important to note that the question, absolutely really interesting to be thinking about that variation that we would see within our cohorts. This is that high level model that's to give us that overall impression. And I'd always be encouraging people, let's start with that point estimate and then let's start layering through. So the answer that I gave in the sidebar was absolutely what we can do is we can actually split off, instead of that just being cohort 1A and 1B that's coming in, what we could do is have a cohort 1A suffix 1 that is representing a smaller group of patients, and therefore the percentages and the average time at stages that we use would be consistent within that one group, and we'd feed that through the model. And there's nothing to stop us then adding together several different cohorts to actually collate them together. I'm conscious that there's been a little flurry of different questions all in this space, some along the lines of, well, what about if we were to actually use real data? And it would be a similar response that I'd be giving to that one, which is, let's start with a simpler model. Let's take that sort of more aggregated view that we know is wrong, but it's all about giving that indication as to what that volume is and when, so that we can improve that validation and ensure that we've got meaningful outputs, and then we can start layering in the different values. But yes, we would be actively encouraging people to be playing around with those values in order to see what impact it has if more of your patients were actually to take longer to go through parts of that system. Hopefully that answers the question for everyone there, Claire. But as has been noted in the chat as well, we'll be doing an FAQs, so I will pull together a more formal answer to share with everyone then.
Okay, thank you. So as we've said, we will take all of these questions away now, and we'll have them answered and they'll be sent out. But we'd also like to thank you for those of you who've posed questions before the event of things that you've been wondering about and wanted further clarification on. So we've taken some of those questions, and I'm just going to pose some of those questions to the panel. So one of the questions that came up quite frequently was, how can this model be used in a community setting? So I'm going to ask Susan if she could cover that question.
Yeah, sure. Thanks, Claire. So I suppose for me, this model can really be applied in all settings. So community, children, young people, mental health, learning disabilities. It's meant to cover the entire spectrum of rehab, because it enables us really to look at and describe different levels of rehabilitation intensity in quite a simple and straightforward way. And I think from a practitioner point of view, it gives you the opportunity to capture the demands on your service, and gives you that opportunity to discuss those demands with your managers, planners, in a data context that perhaps we've never had before in rehabilitation. And that helps you to inform your service model really, and your capacity and the skill mixes that you might need. So for example, for me, I would probably use this model to understand the types of patients that were being referred into my team, what sort of rehab level intensity some percentages might be needing, and then try and use that to sort of shape the workforce really. And I guess it's monitoring intensity demand like this over time will support any sort of service development and enable us to articulate the rehabilitation need in a way that I don't think we've ever been able to do before.
Okay, thank you very much for that, Susan. So we also had a question which was, how would we measure the outcomes in relation to using this model? And I wondered if Michelle could answer that question, please.
Yep, certainly. So as I referred to in the presentation, so there has been a separate piece of work that has been done by another work stream around an evaluation framework that sits alongside that. And again, it wasn't simple, but it was about getting a starting point. We didn't have a standard way of collecting data around rehab to understand the demand or the impact of it. And I think that's going to be a journey in itself. If we can start to move towards a more standardized way and more automated way of capturing our activity and outcomes, I think it would really help to build that picture of rehab provision across Wales and give us really strong evidence about it to inform the planning and service development as well. So the link is in the presentation.
Okay, thank you, Michelle. So another question we had posed was, how do we collect data against the people not actually accessing the services? And I wondered if this is maybe something both Jenny and Michelle might want to cover.
So hopefully with Michelle's permission, she doesn't mind me coming in on this first, because seeing this question sort of brought out that passion in me in terms of modelling. I think it's a big challenge that we've got, not just with this particular piece of work, but in all of healthcare services. So how do we know what our actual demand is? Because who turns up at our front door isn't necessarily who actually needs support, intervention, care. So for me, this is a much bigger question than this particular one, but there are lots of things that we can do. This is where I'm a big advocate of modelling, because actually having a tool that allows us to be asking those what if questions. So what if we have seriously underestimated, or we've currently got such a low provision that we're not actually seeing the people that we think that we should? What would our demand look like if we were to actually have those patients coming through? What would that actually mean for us? So it's to facilitate those what if questions. So I'll hand over to Michelle, because I think, Michelle, you had a similar but complementary perspective.
Sorry, couldn't get myself off mute then. Yeah, and I suppose absolutely agree with that. And I think as practitioners, we're always very aware of that unmet need. But I think there's also an element of us being clear about what our offer is, to make sure often, it's about getting those referrals through and making sure that the public can self-refer and access services, and us being able to articulate what the benefits of rehabilitation are and what the offer is as well. But yeah.
Absolutely. And sorry, just to sort of further that point as well, it's not forgetting that there is evidence out there. So this whole piece of work has been that challenge of, in a new and emerging situation, trying to draw from the evidence base of what would be happening around COVID. That I think applies in general. So this will emerge and change, and therefore having a model rather than just a static prediction allows you to again be playing around and explore the impact of that. Sorry, Claire.
No, that's great. Thank you very much. So, and moving on from that, there was another question on how do you identify those within cohort 4 who would benefit from this model? So, Susan, do you want to come in on that one?
Yeah, sure. I think this is very difficult. And so cohort 4 are those that are socially isolated or shielding. So we've got the information on the numbers of people that are shielding and who they are, but those that are socially isolated, that's definitely not as clear. And I think it's important to say that the evidence is starting to tell us that lockdown has definitely led to a decrease in levels of activity, poorer social connectivity, altered consumption of food and alcohol, and an increase in substance misuse, and that loss of both the physical and mental well-being. So we know that there's a potential challenge there. However, I think it's quite difficult at this time to know what the needs of this particular population group are likely to be. And I guess some of them will appear in some of the other populations, population 2, those that had their planned care paused, and population 3, those that just avoided services. So there is a risk of having these individuals double counted. I would think that the identification of these individuals is likely to be through elements like primary care or the third sector. And I think this is one of the many reasons that we need a collaborative approach to rehabilitation, so that we're able to identify the needs of this group and ensure the correct level of intervention and support. So I think it's quite a hard question to answer, but hopefully coming up with this collaborative approach will enable us to be able to respond to the needs in a timely manner.
Great. Thank you. Jackie, you'll be pleased to have pulled out a couple of questions from you. The first one is, do we plan to have aggregated anticipated demand from 4 cohorts to inform our strategic approach to planning and workforce, and also our plans to flex up and down, and how are we answering the value-based healthcare / prudent questions regarding levels of intensity and outcome? So I'll start you with that one.
Okay, thank you, Claire. Nice challenging question for me there, that one. Okay, so I think that in many respects what we are hoping is that this tool will be used and developed as a tool to evaluate the delivery of rehabilitation services across Wales. But I think that's very much reliant on us starting to think about, are we collecting the right data that can be compared and contrasted across organisations? We've had some discussion with our value-based healthcare team, Sally's team, Sally Lewis's team, about whether we could actually develop some level of a data dashboard for rehabilitation so that we could then take it further forward in order to really begin to strategically look at our demand, look at predicting what our future models might look like, and then wrapping our capacity around that, but also looking at gaps within that, because I'm conscious that, you know, if I think of my own health board, rehabilitation is not a seamless delivery. We have areas where we have fantastic rehab services, but then we have areas because of specialty that don't necessarily have the same level of investment. And I think the opportunity here from a value-based perspective in terms of efficient and effective services is that we understand how we what the need is and what we need to provide to meet that need in the right way. I think one of the biggest challenges will also be around that collaborative working, because this is not something that I believe health boards or primary and community care groups can do on their own. Rehabilitation crosses all of those parameters, as well as third sector, local authority, are highly involved, and I think it's going to be really crucial if we are looking at planning that we recognise that this is going to have to be a combined approach that builds the services for people. So I hope that was Chris's question, wasn't it, Chris Morrell? I hope I've answered your question, Chris.
Great, thank you, Jackie. So just another special treat for you then. So will the modelling and data collected form part of a national indicator, do you think?
So I think I've probably partially answered that question in the one that I did previously. I think that I think the crucial to it becoming a national indicator is the link to the work that Michelle described in relation to outcome measures. So how do we look at the patient reported, the practitioner related outcome measures, and then do that alongside the way that we are configuring our data focused on demand and throughput and capacity, in order to be able to pull that together to make it a national indicator of whether we're achieving high quality rehab services. I think, you know, issues around inequity, fragmentation is one of the, in rehab services, is one of the reasons why, if it was in my gift, I definitely want it to be a national indicator. But I think much of that will depend on the response we get from today's event and how much people in services that are delivering rehabilitation see the value of having a tool like this in shaping the work that they do.
That's great, thanks. So Kerry, one of our colleagues, has been really kindly monitoring all of the questions as they've been coming in. And I'm just going to invite Kerry to see if there's a couple she'd like to pick out of the questions as they've been coming in, which we thank you for, and ask if there's anything she'd think would be useful to pose to the panel. So thank you, Kerry.
Thank you, Claire. I'm aware that some of the questions posed have been answered as as people have been speaking. Two of the questions have come through that are possibly helpful for Michelle to look at, in terms of the first one is the range of rehabilitation, even at the lower complexity, is very high. What would we say is rehab and what is usual activity, i.e. that person does on their own? And then leading on from that, could we just use this model for our whole neurological rehab caseload?
Thanks, Kerry. So with the first question, when we were thinking about intensity, we were trying to think about the broader across health and social care. So trying to understand that demand for, you know, if somebody needs support to walk to the toilet and back. So it is about their normal care, but it's not, as Susan referred to earlier on, it's not just about direct therapeutic intervention. It's about the support from the wider MDT from a health point of view, but also from local authority and also third sector with what they're actually able to do during the day. So that's why it's up sort of, you know, so a low level of intensity could be 3 or 4 reablement calls a day, plus an additional of 45 minutes, plus an additional sort of half an hour of direct therapy. So hopefully that answers the intensity question. And then from a neuro rehab point of view, I think definitely this is something we can use. And I think those of you who have been involved, some of this was informed by some workshops we did with the, we've had a neuro rehab task and finish group that's been meeting for the last 18 months to try and unpick some of the complexity about specialism and rehab on a Wales-wide basis. And certainly that was in my head when we were looking at this, and it did help to inform this modelling work. So I think, yes, definitely individual teams could be looking and using this tool to really sort of give their, sort of grade their different clients into different intensities. Thanks, Kerry.
Thanks, Michelle. Another really helpful question that's come through is, how does the model work with the overlay of multiple chronic conditions? 50% in the no rehab needs category. Does evidence suggest this is the same regarding all disciplines involvement? Thinking of COVID admissions and impact on nutritional risk, but also existing comorbidities requiring support. Any of the panel like to have a tackle with that?
Would you like me to answer that one, Kerry? So I'll take it from a sort of broad perspective, and I'm sure Jenny can come in terms of that overlap work. What we recognise is that when we looked at the cohorts, there is a likelihood that we are going to have people who fall into more than one of those cohorts. So we are going to have people who have chronic long-term conditions that affect them significantly, their health and well-being, and they may also contract COVID and have the after effects of COVID on top of that. When we looked at that figure of 50% requiring no further rehab, whether people were in the community or the 50% from an admitted point of view, and then those that were in the community, that was based on the evidence that was emerging around COVID. Now, what we're very aware of is that our learning and our understanding of COVID is changing and will continue to change, as it does for all health, well-being challenges. So it may be that at some point in the future, new evidence will come to light, or you as a group may provide us with different evidence that influences what the numbers look like in terms of those cohorts that either require intense, moderate, intense, high intensity, moderate intensity, or little or no rehab. Jenny, I don't know whether you've got anything to say on the particular modelling aspects, the data-driven aspects.
Yeah, thank you, Jackie. No, I think it's really important to remember. I refer quite regularly back to the right sizing community services work, because even though there was one model that was Professor John Bolton and the IPC developed, ultimately when we went out to the RPBs and were running with that work, there was the different slants that were needed locally in that everyone had to come up with their own definitions. And I think that holds true for this. So what's really needed in that case of where comorbidities come in is, what's your definition of those cohorts? So are you accepting that there's a double count in order to actually just sort of appreciate that all of those different pathways that individual patient might require all accumulate? Or are you going to add a definition whereby once they're captured in one cohort, they get closed off? And that's because as much as we can pull from the evidence, and the model that's been published illustrates, there's a range in terms of the percentages of patients that we would expect to flow into each stage. And there's also a range in terms of the expected time. Now, you and your knowledge of your system locally and what it is that is actually making up that cohort provides that insight as to sort of squeeze some of those percentages and make those adjustments. So this is where it's quite a strategic model at this stage, but the aspiration would be, as the data starts to improve, because hopefully this model provides that burning platform, that evidence base as to why actually capturing some of this data is really, really valuable, and capturing it in a way that can be readily put into the model is very helpful as well. Then it means that you can start to tailor and refine that. So we're not trying to be too prescriptive with it, but in terms of the overall model structure, there is absolutely nothing to stop you from actually breaking apart some of the stages further. Hopefully that helps contribute to that answer.
Thank you, Jenny. Carrie, did you want to come back in there?
I suppose it was just to pick up again with regards to Jackie's around the evidence. We really did seek what evidence was out there to inform this model, and as has been outlined, looked at sort of across at earthquakes and wider. And I have a plea out at the moment with regards to evidence in terms of what difference could we make as AHPs in terms of it mitigating the impact of COVID. So all of this together really sort of informs this picture and this iterative model. Additionally, with regards to data and the National Data Hub, we are moving closer to getting AHP data included, and that National COVID Data Hub is going to extend to sort of COVID and non-COVID. So we have a real opportunity to put forward data across the full population from an AHP perspective that again can really inform this as a modelling resource.
Right. So Carrie, I think we've got probably time for just one more question if there were any we needed to answer on this session rather than put it into FAQs. Are there any more?
Just having a look, I think perhaps whether it's helpful to just go back to one of the first sort of threads that came through. There was a question raised in terms of are the weeks in each stage assumed, or is it based on actual outcomes? And then they went on to the question developed in terms of lag. Does the model capture any lag as model present, or move on, but some will not? So figures based on average ? So whether, if I invite Jenny to come back with that, just to perhaps reiterate for people if people perhaps missed that.
No, absolutely. So for the demonstration that Richard was giving, because it's quite difficult to see a line on a graph that just sort of shoots up and shoots back down again, we implemented that 2-week in order to essentially reflect how a patient admitted into hospital then on average, and the average for COVID that was recognised early on was a 14-day stay. So that's what that 2-week window was implemented based on, but it was also there to support us seeing that difference of the graphs moving afterwards. However, within the group, we acknowledge that a patient may actually access or have rehab needs immediately on admission. So all of those are parameters that can be changed. However, all of the numbers used in the presentations were based on the literature and the evidence base. But what we'd be actively encouraging people to do using the tool is to look at the sensitivity of the outputs to any changes in those parameters. So to do a point estimate of 1 week, actually, is it more like 10 days, etc., in order to play around with it? Hopefully that gives a clear enough answer.
Okay, so thank you for all the questions, lots of them posed there, and we will endeavour to answer all of those. So I'd just like to ask Jackie to join us again and just to explain what the next steps are. Jackie, please.
Thanks, Claire. You'll be aware that some of the messages that have run through this is that this is at a very early stage of development. We feel we're incredibly proud, I think, as a group, that we've actually got this over the line in a relatively short period of time. because we started the work in May. But what we need now is you. We need you to be asking the questions that you're asking in the chat bar. We need you to be checking out with us the assumptions that have been made within that and where we've drawn the evidence. We need you to correlate whether what you are seeing in your practice actually reflects what we are representing within the model. I think in terms of what we need you to think about is very much around that data that you've got that will help you to test the model. And I think one of the key aspects for us is the fact that you go and try to find out, if you don't already know, in your organisation who can help you to gather that data. Finding data can be really hard, and we're not always collecting or being informed by all the data that's out there. So I think this is an opportunity for you to get to know your informatics teams better, to talk to your data analysts, to talk to your business intelligence team, or your planners, anyone that can help you to find data and potentially influence what data you might collect in the future. I think we're also keen that you start to talk locally with your senior managers, exec leads, anyone who has a responsibility for rehabilitation services, whether that's from a practitioner or a operational or a strategic sense. I think it's really important that we get the people interested in this at all levels of the service, so right across the continuum. I think it's really helpful to use COVID data from your area to get used to the model. So I quite quickly, when we started this work, I was asked to do a presentation for our exec teams in Iron Bevan around, do we have the resources to meet the need for rehab, particularly for patients who were post-COVID? And it was really helpful to be able to go into that presentation and run through. I had all the data. I knew exactly how many people had been admitted. I was able to use the predictive data to go on the basis of that. That probably means that we've got this many people out in the community who've had COVID. And then to break that down into what that would mean for the health board in terms of changing the way that we delivered services in order that we could meet the needs out there. And I think they were really reassured by the level of detail that we were able to present at that meeting. And I think that's something, it's a great way of almost like testing whether you understand it and looking at whether you need a little bit more help, or how you might translate that into a different part of the service. So I've started thinking about, our stroke services, and could we actually use that model for stroke, and would that work, and etc. So I think it's an opportunity to play a little bit with the model. For us, most importantly, we would love you to express interest in being part of this work moving forward. You'll see on your screen there's a link for you to contact, an email link, so that you can express interest if you haven't already done so. And I'm aware that many of you, when you registered for this event, had put that you would be interested in working with this group to take this forward. We need more clinicians giving feedback. We need more practitioners in local authorities. We need people in primary care. We need people in non-statutory sectors. We also need definitely some feedback from patients in terms of what this means to them, from the people who might need rehabilitation. And I think we're very keen to have any of you on board to do this work with us. What we plan to do next is, Michelle has already started a how-to guide which talks through how you might use the model that we will all contribute to, and then that will become available. We've already mentioned the frequently asked questions, which we will respond to, and then make that something that goes out to everyone who has been part of this event, and for wider cascade and availability. And also we've recorded this event, so that means that colleagues, anyone who hasn't been able to either attend for the whole of it or any of it, can actually review the event. We're looking to develop some champions. What we want is that local network. So the idea of having, thinking about the Gwent patch that covers an Iron Bev, and we would like champions across all the services that deliver rehab in different hubs to enable us to start to test some of this more locally and look at whether we can access the right data across the Gwent patch to know what the rehab needs of our community are. We're looking at virtual networks. I think Jenny is very keen on how she can translate some of the work she's done with her modelling networks to enable that to happen. And we're also looking to some of our DOTHs and DONs and various exec leads and heads of service to become regional links for this work across Wales. We hope also that we will continue as a group, that this group will continue, but with input from you to develop the model further. So I think the success of this, or our ability to take it forward, is now to a large extent dependent on teams and individuals wanting to take this further and work with us, with our support, with our, the learning that we've made along the way to develop this into a national piece of work that will be used really widely. That's all from my point of view. We will be circulating this, but I'd like to take the opportunity to hand over now to Ruth Crowder. Ruth, as probably everyone knows, is our AHP advisor for Welsh Government and was the person that instigated all the work around rehabilitation post-COVID. So she has led and driven and supported us all to get this work over the line, even when at points we probably thought we couldn't do it, particularly around the modelling. Ruth is also policy lead for rehabilitation for Welsh Government, and I think it's a real representation of how AHPs are seen as those professions that really do contribute huge amounts to rehabilitation. We are not the only professions that do, but I think there is an opportunity here for us to really start to drive some of the way that rehabilitation services are delivered. So I'm going to hand over to Ruth.
Thank you, Jackie. Thank you for those really kind words. As you'll notice from how much you're seeing me today, the reality is that everybody else has done all the hard work and I have literally been in the background. So I really do want to thank everybody who's presented today. I want to thank all of you for participating. I think we have 123 people here. You can see the event team up on the screen there. This is quite phenomenal. They've developed the resource. They've contributed to the wider development of the rehabilitation framework, and they've invested significant amounts of skill and time in preparing for today's event. And I'm seriously impressed at the way they manage those tech gremlins that get into every one of these. So huge thanks to all of you. You've all heard how, as the evidence grew of the likely rehab plan from COVID, that we developed a multi-professional, multi-agency group that was cross-sector, and this work is cross-sector and will continue to be cross-sector. We need to make sure that we can make a significant difference for the whole of health and social care in Wales. That group developed a rehabilitation framework that is the first in the UK. And for the first time in Wales, we've had a policy focus on rehabilitation, reablement and recovery. And this aligns really closely with our National Health and Social Care Strategy, Healthier Wales. That has such a clear policy vision for enabling all citizens to be able to lead longer, healthier and happier lives, with care provided as close to home as is possible, but care definitely focused on enabling them to live as independently as possible. Only within a whole system culture, focus and expectation that prior to or following a medical, surgical or psychiatric intervention, the right prehab or optimization, the right rehab, reablement and recovery focused intervention can avert a health crisis and maximise recovery from it. So I'm really proud of everybody who's contributed to the development of the framework and the guidance. Our health and social care system is and needs to be an outcome-focused system. So not only did that Task and Finish group develop the guidance based on international evidence, they further recognised that we needed these two tools in order to be able to make it effective. First, as Jackie identified, the evaluation framework that we're also quite keen for you to test and give us feedback on, but also this. I echo what Jackie has said. Please, actually, when you signed up, around 3/4 of you have already identified that you are willing to work with us in our future programme. So please don't feel pressured if it's not right for you. But the more of you that do that, the more right we can do it. We want to be able to validate it, consider how you can utilise it and generate the data to help us make sure it's right and it works for the people of Wales. I think it's always a dangerous statement, but I think this is the first model of this kind focused on rehabilitation in Wales. And I do hope that our modelling team will look at how they can make sure that this is published to help wider than just Wales understand the real impact that we have. So I want to thank you all so much for expressing interest. We will keep your names, as we said, only for this, but we will be in touch with all of you to make sure that we work with you, explain to you how we're going to finalise the programme and make sure that we have a real way of moving forward from this. And look to support you and work with you as a community of practitioners for all of our professions and across the whole of our health and social care system to make sure that we deliver rehabilitation, reablement and recovery services that enable all our friends, families and communities to live the life that they want to. So thank you all again for today. We will keep in contact with you. We will send you the link to the recording and the facts. It remains only for me to say, when I finish speaking, we will finish the meeting. So stay safe, look after yourselves and each other. Enjoy the summer. I have my fingers crossed for no second wave in the winter. And thank you all for everything that you've done over the last 6 weeks, months even, 6 weeks, 6 months. Which have been completely unprecedented, and I really appreciate everybody's commitment. So stay safe. Thank you very much for today again, and all best wishes for the rest of the summer. Goodbye.